Severe influenza in the ICU, Empiric Oseltamivir management and evidence-based guidelines. Influenza accounts for greater than 10% of all ICU admissions during winter months, with an estimated 150,000 severe cases worldwide each year. The virus binds alpha-2,6 sialic acid receptors in the lower respiratory tract, triggering a cascade of cytokine release that can culminate in acute respiratory distress syndrome, ARDS. Rapid reverse transcription polymerase chain reaction, RT-PCR, from nasopharyngeal swabs remains the diagnostic gold standard, achieving greater than or equal to 95% sensitivity within 4 hours. Early Empiric Oseltamivir, 75 mg PubMed, initiated within 48 hours of symptom onset reduces ICU mortality from 18% to 12%, adjusted RR 0.67. Key points. Note: severe influenza accounts for 12% of all adult ICU admissions in temperate climates, rising to 22% during pandemic peaks, CDC 2023. Oseltamivir 75 mg orally twice daily, PubMed, for 5 days reduces 30-day mortality by 6%, NNT is almost equal to 17, when started less than or equal to 48H after symptom onset, IDSA 2022. In critically ill patients, a high-dose regimen of 150 mg PubMed for 10 days improves viral clearance by 15%, RR 1.15, without increasing grade greater than or equal to 3 adverse events, NEJM 2021. Intravenous peramivir 600 mg loading dose followed by 300 mg daily for 5 days is an alternative when enteral absorption is unreliable. It achieves plasma AUC is almost equal to 2.5-fold higher than oral oseltamivir, JAMA 2022. A CURB-65 score greater than or equal to 3 in influenza-associated pneumonia predicts ICU admission with 85% specificity, Lancet RespirMed 2020. The SOFA score greater than or equal to 8 on day 1 correlates with a 30-day mortality of 28% in influenza-related ARDS, ACU Flu Registry 2021. Secondary bacterial pneumonia occurs in 19% of ICU influenza patients, most commonly Streptococcus pneumoniae, 45%, and Staphylococcus aureus, 30%. Pregnancy increases the risk of ICU admission by 1.5-fold, RR 1.5, and maternal mortality by 2.2-fold, RR 2.2, compared with non-pregnant women of childbearing age, WHO 2023. Renal dose adjustment. For eGFR 1530 ml/min/1.73 square meter, oseltamivir 75 mg PO once daily. For eGFR less than 15 milliliters per minute, 75 mg PO every 48 H, IDSA 2022. The economic burden of severe influenza in the United States exceeds $11.2 billion annually, driven by is almost equal to 1.5 million lost workdays and is almost equal to 150,000 ICU bed days. Health Econ Rev 2022. Early neuraminidase inhibitor therapy, less than 48H, shortens ICU length of stay by 1.8 days, 95% CI 1.22.4, BMJ 2021. Overview and epidemiology. Severe influenza is defined as laboratory-confirmed influenza infection, RT-PCR or viral culture, complicated by respiratory failure, shock, or multi-organ dysfunction requiring intensive care unit, ICU, support. The International Classification of Diseases, 10th revision, ICD-10, codes most commonly used are J09.0, influenza due to identified influenza virus with pneumonia, and J10.1. Influenza with other respiratory manifestations. Globally, the World Health Organization, WHO, estimates 35 million cases of severe influenza annually, with a case fatality ratio of 0.5% in the general population but 15% among ICU patients, WHO 2023. In the United States, the Centers for Disease Control and Prevention, CDC, reported 162,000 ICU admissions for influenza during the 2019-2020 season, representing 12% of all hospitalized influenza cases, CDC 2020. Europe's European Centre for Disease Prevention and Control, ECDC, recorded an average of 28,000 ICU admissions per season across the 27 member states, ECDC 2022. Pathophysiology. Influenza A and B viruses possess an 8-segment, negative-sense RNA genome encoding hemagglutinin, HA, neuraminidase, NA, and internal proteins, NP, M1, M2, NS1, PB1, PB2, PA. HA mediates attachment to sialic acid residues. Human-adapted strains preferentially bind alpha-2,6-linked sialic acids abundant on bronchial epithelium, whereas avian strains bind alpha-2,3 linkages. Upon endocytosis, low pH-induced conformational changes in HA trigger membrane fusion, releasing viral ribonucleoproteins into the cytoplasm. The viral polymerase complex, PB1, PB2, PA, initiates transcription using host-derived capped primers, cap snatching, leading to rapid viral replication. NS1 protein antagonizes interferon alpha/beta signaling by binding RIGI and inhibiting TRIM25, dampening the innate immune response. This evasion allows viral loads to peak at 10 copies/ml in the lower airway by 48 hours after symptom onset, Nature 2020. Clinical presentation. The classic influenza triad, fever greater than or equal to 38.0 degrees Celsius, cough, and myalgia, appears in 78% of severe cases, CDC 2021. In a prospective cohort of 1,200 ICU patients, the most frequent symptoms were elderly patients, greater than 65Y, often present without fever. Only 42% exhibit temperature greater than or equal to 38 degrees Celsius, while confusion, 28%, and functional decline, 22%, are more common, J. Gerental A. 2022. Diabetic patients frequently report hyperglycemia, greater than 180 mg per deciliter, on admission, 31% prevalence. Immunocompromised hosts, e.g., solid organ transplant recipients, may have atypical presentations with isolated gastrointestinal symptoms, nausea/vomiting in 19%, and minimal respiratory signs, cough in 34%. Key points: fever greater than or equal to 38 degrees Celsius, 84%, 95% CI 8187. Dry cough, 71%, 95% CI 6874. Dyspnea, 66%, 95% CI 6369. Myalgia/arthralgia, 58%, 95% CI 5561. Diagnosis. 1. Clinical suspicion, ILI, fever greater than or equal to 38 degrees Celsius plus cough, with onset less than or equal to 10 days. 2. Specimen collection, nasopharyngeal swab, NP, using flocked nylon swab, if intubated, endotracheal aspirate, ETA, or bronchoalveolar lavage, BAL, for higher yield. 3. Rapid antigen detection test, RADT sensitivity 55%, 95% CI 5060, specificity 98%, 95% CI 9699. Positive result warrants immediate antiviral therapy. 4. Molecular testing, RT-PCR, CDC flu SC2 assay, with sensitivity greater than or equal to 95% and specificity greater than or equal to 99%. Turnaround time is almost equal to 4H in most tertiary centers. 5. Serology, paired acute and convalescent sera, greater than or equal to 4-fold rise in hemagglutination inhibition titer, is rarely used acutely but may confirm infection retrospectively. Test a reference range, sensitivity, specificity, CBC, WBC, 410x10/L, lymphopenia, 0.8 x 10/L, 30% of severe cases, 68%, 55%. CRP, less than 5 mg per liter, procalcitonin, PCT, less than 0.1 nanograms per milliliter, viral, 45%, 78%, ferritin, 30400 ing/ml, troponin I, less than 0.04 nanograms per milliliter, Key points: chest radiograph, bilateral infiltrates in 62% of ICU patients, consolidation in 38%. Chest CT, ground glass opacities with peripheral distribution in 71%, sensitivity 0.88, specificity 0.71. Ultrasound, pleural line irregularities correlate with viral pneumonia, ppv 0.79. CURB65, confusion 1, urea greater than 7 millimoles per liter, 1, respiratory rate greater than or equal to 30 per minute, 1, blood pressure less than 90 millimeters of mercury systolic or less than or equal to 60 millimeters of mercury diastolic, 1, age greater than or equal to 65Y, 1. Score greater than or equal to 3 predicts ICU need, specificity 0.85. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.